Okay, so just picking back up, we talked a lot about, well, let me clarify something real fast. So in the beginning, you all looked at me like I was crazy when I asked you about Axis 1 through 5. So up until the most recent change with the DSM, everything went off of Axis 1, 2, 3, 4, 5. And with the most recent change, they're moving away from that. However, almost every psychiatrist that you will do your rotations with is going to have been trained longer ago than within the last 3 years. And they're all still going to pretty well be operating off of that mindset. And really it's a mindset of you understanding that a psychiatric patient is still a comprehensive model of assessment and management. For so long, psychiatry focused only on Axis 1, Axis 4, and Axis 5. So they really kind of would dabble in Axis 2 and disregard Axis 3, which is your medical conditions. Well, in the last 10 years or so, psychiatrists have been forced to have to deal with general medical conditions because anecdotal and post-marketing evidence has shown so many of the medicines that we use to treat psychiatric conditions can lead to the development of metabolic conditions and other types of things. And so psychiatrists used to be, oh, I don't do vital signs and take weights and blood pressures and send people for lab work unless maybe they're on a Depakote or lithium or they're on a Clozaril and having to look at. Have you all talked about atypicals? Mm-hmm. Oh, my favorite. So I mentioned Clozaril. I'm going down a weird path, but Clozaril. Why is Clozaril not a first line? Because it's pretty effective. It's an effective atypical. Why is it not a first line atypical antipsychotic? Side effects. Well, that's a broad.
Good answer. That's good.
Agranulocytosis. Who said that? Ding, 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 ding. Yes. So, if I have a patient who suffers from schizophrenia, and it's a 26-year-old female, and she is married, and she becomes pregnant. What is the only atypical that is a class B? Come on, come on, come on, come on, come on. We just talked about it. Clozaril. I wouldn't bait you into having to tell me another drug. So Clozaril is a class B atypical. So although it carries risk of agranulocytosis and you have to be doing regular blood work, it can be a very effective medication, and but it is a class B when it comes to treating women who may become pregnant while needing treatment concomitantly for their serious or significant psychiatric condition. So nonetheless, the Axis system, we're sort of moving away from that, but I can guarantee you the psychiatrists that you rotate with, you're still going to have discussions of the Axis system. You're going to still see it in standardized exams for a little while as we're transitioning away from that. I can tell you on the psychiatry CAQ, we're still coding 9 and 10 ICD-9 codes simultaneously, so that as we're transitioning over, kind of people can kind of see where that's going, and so we do give the test taker a little bit of benefit of both those, the coding there. So, but you're not crazy when the Axis 1 through 5, but it's still there, it's still being used somewhat, but you need to realize what that Axis system did was make you think about a psychiatric patient as a whole, a continuum, not just a mood disorder. We still have to take into account general medical conditions, because you look through the DSM, how many conditions can be secondary to a general medical condition, okay? Most common cause or reason for admission of an elderly woman to the geriatric psychiatric unit.
UTI.
Yes. So we've had a potential psychosis secondary to a general medical condition, and we treat the medical condition, and the psychiatric diagnosis resolves. So we have to treat those patients as a continuum, not just as psychiatric diagnosis. Let's go to here. So intoxication versus withdrawal. So just because somebody becomes intoxicated on a substance doesn't mean that they necessarily have a misuse or an abuse of that particular substance, right? Somebody can ingest alcohol and become intoxicated, but they don't necessarily misuse the substance, nor do they have an addiction or a tolerance. So we can still become intoxicated to a substance and not have abuse. But in this particular slide, I want you to be thinking about intoxication from the standpoint of somebody who is regularly misusing a substance, because regular users can still be intoxicated, correct? They can still have changes in multiple functional areas of their brain and self such that they exhibit behaviors of an intoxicated individual. So I want you to think of here intoxication as it pertains to somebody who is routinely using or misusing a substance of abuse, and then withdrawal, the abrupt cessation of that. And this basically just highlights the two polar opposite things that are happening with the neurochemical systems and their resultant behavioral changes or manifestations in intoxication versus withdrawal. So what happens? The acutely intoxicated or chronically intoxicated, dopamine, we're euphoric. Withdrawing, we're dysphoric. What are we doing when we're activating opiates? We're getting analgesic. What happens the other way? So these are just polar opposites of one another's, but it's good for you to think of, again, in you becoming experts at identifying patients through questions. You're going to then become experts at your history taking and identifying patients in the real world. You start using this as sort of polar opposites. If somebody comes in presenting of X, Y, and Z, and you know that they've had some sort of substance use related issue, you can start pairing through what is it, what substance am I needing to be looking at, and is this a potential life-threatening situation? Is it opiates, or is it benzodiazepines, or is it alcohol, or is it cocaine, or whatever it may be. This is the third most exciting slide that we will see this afternoon. And it basically shows sort of, and I told you in the beginning there were lots of terms, but this kind of shows you receptor habituation, if you want to use that term. So these are chloride channels with dealing with GABA receptors, and it's just an illustration of GABA by itself, and then what happens with those chloride channels when alcohol is administered, not directly to those chloride channels, but the activation of those neuronal networks that deal with the chloride channels. What happens in acute intoxication, but then what happens when we chronically use that substance? We go back to the norm and then some. So this is where we start looking at receptor downregulation. Have you all heard that term before? So we actually start seeing that with chronic use, and this just isn't with alcohol. Alcohol is just using as an example here with chloride channels. But with chronic use of substances, especially substances of misuse or abuse, we see that the receptor density changes and the individual receptor's response can change. Okay? So what this is highlighting is that when we are in the beginnings of acutely using this substance, how these chloride channels are activated, but once we use them habitually for a period of time, those receptors or those chloride channels are functioning now less efficiently, less effectively with the introduction of that substance. So then this helps you to realize why then somebody can develop tolerance, and why then people have to start using more of a substance to get the same effect, right? So this is a great illustration, not because I want you to think of only alcohol deals with GABA and chloride channels. That's not the main point of this slide. The main point is it's here for you to wrap your brain around. There are physiological responses that happen with the acute administration of substances, but chronic administration will also, in turn, have physiological manifestations on the way the receptor performs and the density of those receptors over time. And this is why then it may take more of a substance or more frequent dosing of a substance to elicit the same pleasure response in that pathway. So how do we develop all of this? In the beginning, we have a standard set of receptors that we're activating through this pleasure pathway. But as we chronically administer a substance, the number of receptors gradually increases. So we have a receptor upregulation. Okay, we have an increased number of receptors, but we have a neurotransmitter depletion. So we have more receptors and we have less neurotransmitter to interact with that number of receptors. So now it takes more of the substance to get more of the neurotransmitter to be released presynaptically to try to bind with those larger number of receptors that are postsynaptic so that we can innervate the pathway. So you see how it's this catch-22 circle, that the more we use the substance, the more the physiology changes, the more we have to introduce the substance so that we can combat what has happened within the physiology. So again, putting the last slide sort of in words. And then once we've done this though, once we've had an increased number of receptors and a decrease in amount of neurotransmitter, we're starting to build tolerance, correct? That term basically meaning we've been habitually exposed to whatever substance or activity. We're tolerant to that and that it doesn't provide the same reward response that it did before. And we're now needing to utilize more of that substance and our behavior to elicit the same response. Okay? So, the first time you ever wrote, yes sir?
When you say the receptors, are you saying the postsynaptic receptors or the reuptake receptors?
It can be either one, because it depends on which substance that we're dealing with. But you have to think of it, you're having both pre and postsynaptic changes, and that could be with reuptake inhibitors, reuptake pumps. It could be with release of it from presynaptic. So you're really dealing with pre and postsynaptic receptor dysregulation. Okay? So the first time you rode roller coaster, you probably wanted to pee your pants, right? But after you rode it 6 or 7 or 8 or 10 times, it may not make you as anxious as it did before. Correct? First time you got behind the wheel of an automobile, I mean, it's an anxiety-provoking experience. When I see you people driving, most young people, I get out of the way because it's an anxiety-provoking response on my end, because my 17-year-old daughter scares the living you-know-what out of me. But as you've driven and engaged in that activity more, your angst is less. Now you've become more experienced, you have more muscle memory. But what have you done? You've built a behavioral tolerance, correct? So the reason I bring that up is that tolerance is not just a phenomenon from a substance use perspective, okay? You have 3 curtain-climbing apes under the age of 3 in here. You know, in the beginning, it may bug the heck out of us, but over time, you learn to build some parental tolerance with curtain climbing apes. And so what is happening? You build a behavioral tolerance to dealing with certain things. And so tolerance is a wide encompassing term, but here, basically what we've done is we're looking at tolerance from the reinforcing perspective of what that drug can do to the reward pathway, meaning that we're getting less of a reward activation from the same amount of substance. So now we're having to increase our substance amount to get the same reward. And if we take that away, or if we quit activating those reward pathways, then we can get withdrawal symptoms. So we now have some physical dependence. Now, just because somebody is physically dependent, does that mean that they've misused a substance? Does physical dependence equal a use disorder? No. Have you had cardiology? Clonidine. Folks who are on regular use of clonidine, and you abruptly withdraw it, what can happen? Rebound hypertension. So has their body built some, in the general sense of a word, tolerance and dependence because they go through a physiological withdrawal if we take it away? So dependence, tolerance, withdrawal, those are not just terms of misuse or abuse or substance use. They can be in any aspect of medicine, because we become tolerant to antihypertensive agents, or is somebody dependent? Let's say we have a diabetic patient that's on insulin, and I withdraw their insulin therapy. What's going to happen to their blood sugars? They're going to potentially go back up, right? So is their body technically dependent upon the use of that insulin to keep them within a normal glycemic control index? In the general sense of the word, yes. So I don't want you to use the term dependence, tolerance, withdrawal to only describe pathology, because even patients who are on other substances can have those symptoms. Now, somebody that's in my clinic that's on an opiate, and they have abrupt cessation of use of the opiate, just because they go through withdrawal because they had physical dependence and tolerance, does that mean they were misusing the chemical? Does that mean they were misusing the substance? Not necessarily. So also don't think of somebody who has tolerance, dependence, withdrawal, don't just lump them into a misuse category, because we can have people appropriately utilizing medical treatments that can still go through withdrawal, even if they're chemicals that could be misused by patient X but are not being misused by patient Y. Okay? So this teeter-totter is kind of important, and this goes back to what I talked about in the very beginning about which part of your brain develops first. Your older parts of your brain, and then orbital frontal, prefrontal, your cortex develops at the end. Why is that? Because we can, oh, there's a U that I missed. So the development of addiction or addictive behaviors. So we're basically activating pathways that are in older parts of the brain that sometimes, depending on the age of the individual or the developmental state of the individual's cortex, there's a reason why then they continue to engage in that, because some of these older areas of the brain can actually override some of the newer areas of the brain. Okay? So this is just a little pictorial description to kind of put it in easier to see. Sometimes words are good and sometimes pictures are good. That there are true long-term changes in the physiology of the brain in people who use substances. So there's a big debate in medicine on, is addiction a disease? And I'm not going to debate that one way or the other. But we do know that there are physiological and structural changes that go on in the brain of these individuals. We also know that some of them have physiological and structural preconditions which may predispose them to misuse or abuse. So we do know from one side of medicine that yes, there could be a component of disease, but that is, in the beginning when I showed you there were biological, personal, and environmental factors, that's the biological factors. The disease portion may be the structural changes and or the preconditional changes that are in these people's brains. But this is a nice little picture that shows prolonged abuse of certain substances change the brain. So this is just an example of somebody who used methamphetamine, not just once or twice, but was a habitual user of methamphetamine. And what is striking about this? Yes. So what have we done then, if we think back a few slides ago when I talked about receptor numbers increase? And so what are we doing? We're starting to activate different areas of the brain that wouldn't typically be activated because we've had an increase in receptor numbers, and we're having to make this brain do different things because of its repeated exposure. So the physiology of this brain has changed. Now the question becomes is, can we change it back the other way? And I don't have a slide about that. So, genetics. So we know that environment and heredity, environment and heredity, environment and heredity. So genetics plays a role. Okay? So you can take the gorilla out of the jungle, but you can't take the jungle out of the gorilla, right? So genetics plays a role in addiction. We know through lots of study. There's been some great studies at OU in the biological psychology department with alcohol. For years they've been doing really good research looking at genetic predisposition for alcohol and other substance use disorders. But we know that there is a significant risk of substance use disorders that run in families. And this is part of the reason why one of the tools that we use in evaluating all of our patients for chronic pain, or if they're going to be on a controlled substance from in sleep medicine, is that we use the opioid risk tool. And this risk tool includes family history of substance abuse, prescription drug abuse, and alcohol abuse, personal history of those things, gender and age, personal history of abuse as a child or adolescent, and psychiatric disorders. So we know that the individual's risk for a misuse is multifactorial. It's not just one thing. It's not just because I have a first-degree relative that had an issue with methamphetamine abuse or misuse doesn't mean that the first-degree relative is going to develop that. Now, are they at an increased propensity for? Do they potentially have some physiological or structural brain Pandora's box that can be opened up by initial use of that particular drug because they've got a genetic predisposition? There are some in the field of science that would say absolutely yes. The genetics play a big role in this, and I will tell you from seeing these patients over and over and over and over, it's astounding how many patients that you see who chronic pain runs in their families and they're all on opiates, 4 generations plus, nieces, aunts, uncles, kids, grandkids. How many of them have substance abuse disorders? How many of them have concomitant mood disorders? How many of them, this all runs together? Now the question becomes is, were they all genetically predisposed? Or is it a learned behavior because that's what's going on within the hierarchy of the home? It's hard to tease some of that out, but they both interact there together. So this is a primate study. So we've been beating up on rats, and this is actually a primate study. And what this study showed is the environmental influence on the potential development of a substance use issue. So those whom were beat up or bullied were more apt to use an inappropriate substance. And this, it doesn't have to be cocaine. So social rank, if we want to use that term, that's the term that they used here in this study. Socioeconomic status, socioeconomic class, however you want to look at it, does place individuals at increased vulnerability for substance abuse or misuse. And we've seen it in public health data, in human studies, and it can be reproduced in animal studies. And this is just an example of how that can work. So basically, these were dominant primates and subordinate primates, and the ones that were subordinate found a way to deal with their potential social angst because of their class status. And they readily used substance of abuse, and whereas the dominant class did not. So why is it that addiction is so prevalent as it pertains to the development in young folks?
Because we're still developing our content.
Still developing their cortex. So the I'm an idiot versus I'm not an idiot part of the brain isn't yet fully functioning. So during childhood and adolescence, the orbital frontal, prefrontal cortex, the start, stop, the yes, no, is this good, why is this good behavior, they're not fully functional there. And this is why boys do dumber things longer than do girls. Because why? The female brain matures a little earlier, right? And so it's way back to the beginning of this lecture when I said, think about how that brain is developing from primitive brain up through cortex, and prime example of why young folks are at much greater risk of developing substance use disorders because of cortical development. So this is just putting all that into words that we've already talked about. So why then are adolescents at greater risk? Because you've got an imbalance in what that frontal cortex is able to do. So we engage in riskier behaviors. We want to have more of that pleasure part of the brain activated because it feels good. And we just don't plan very well, and we're impulsive. What type of patient does that sound like in your psychiatry world? What types of patients are impulsive? They may spend money without regard for their families or financial situations. They may engage in sexually promiscuous behaviors.
Bipolar.
Ah, yes. So what's the difference in mania and hypomania?
Severity is like length of time.
Duration. Yes. Duration is your biggest kicker there. Yeah. Good. Somebody's taught you well. So, again, these just kind of show that that teeter-totter is well weighted over into these pleasure pathways of the brain. And they override the not fully developed, not fully formed orbital frontal or prefrontal cortex. And there's some argument in that if we start using substances at earlier ages, are we preventing the full development of cortex? Are we preventing the ability of it to get to the full mature state of yes, no, start, stop, good, bad? That's a hard question to answer. Because you can have people who come off of these substances, who rehabilitate and go on and do great things. And you have others who rehabilitate off the substances, and you wonder what kind of ball-peen hammer they've been hit with in the front of the head, because it just doesn't seem to click in there anymore. And so there's sort of a debate in why in some can we rehabilitate, and they're very productive folks without any structural, physiological, or cognitive abnormalities, and other folks is that they were already predisposed genetically, structurally, physiologically, and they're just not going to overcome that anyway, whether the substance was introduced or not. It's hard to tease a lot of that stuff out. They've done a lot of twin studies, that you may have twins that were either separated at birth or in different families or even grew up together, and one was a substance user and the other was not, trying to figure out what in the world makes these people click. They should be nearly identical folks here when it comes to obviously genetics. Is it purely because of the environments, if they were in separated families, or if they were raised in the same environment, so they've got the same environment, the same heredity? Why is one versus the other? And twin data is really, really neat, but you kind of chase your tail in it. Sometimes you're like, at the end, I don't know what was proven in this, because we're still asking the same question, we don't know. So treatment. Alcohol. We're going to go through a few things that can be done pharmacologically. So naltrexone can block, and I told you we weren't going to go through mu kappa delta, but naltrexone works the mu opioid receptor, reducing the rewarding effects of alcohol. The second one there is Campral, C-A-M-P-R-A-L. It's been out on the market now for probably about 10 years. Somebody has to be pretty motivated, because this particular medicine is used in folks that are trying to become abstinent. They may still be trying to taper their alcohol use instead of abrupt cessation. And so these people have to be on a very specific plan for dose reduction with their alcohol intake while they're on this particular medication. It can be very effective, but it's sort of a difficult one to get folks to really work through the process. Antabuse. Have you all talked about antabuse? Disulfiram. So the tough part with that is you have to have, in my opinion, if somebody's motivated enough to take disulfiram, they're not dumb enough to go drink afterwards to make themselves really sick. And so disulfiram, I think, was oftentimes used in say, halfway homes or in outpatient rehabilitation centers, where they would purposefully make the individual ingest the substance to try to dissuade them from going and drinking. It's pretty hard for me to think that somebody who's very motivated to not utilize alcohol and taking disulfiram willingly would then go out and make the dumb choice of going to drink knowing what it's going to do to them. But disulfiram is still used, yes.
And even if they did, wouldn't it reinforce it via the, like you were saying earlier, if you go and get food somewhere and you get poisoned by it, then you don't want to go back. So
They shouldn't want to. Once they've gotten as sick as they would get sick after ingesting alcohol, taking Antabuse, you would think they wouldn't want to do it again. However, I have been exposed to patients that they'll continue to do it. So there's something not right in the news. So heroin or opiate, we can use methadone, buprenorphine. Buprenorphine is actually a fairly effective pain medicine, so is methadone. But both of those are used for opiate dependence treatment. Obviously, nicotine patches, gum, lozenges. The state has a free program called 1-800-QUIT-NOW that will allow patients a quit smoking coach and some smoking cessation counseling, as well as patches, gum, or lozenges for 30 days while they're trying to look at quitting. This last drug here, it was an interesting drug in Europe, and it actually blocked cannabinoid receptors, and this was used initially for the treatment of obesity. The problem is that there were significant neuropsychiatric side effects to this drug, And it never gained approval in the US, and it was taken off the market in '08. Why do I put it up here? Is because cannabinoids are, receptors are prevalent in the brain. There can be some scientific benefit to those receptors and/or cannabinoids themselves, and we're trying to figure that out. But this particular drug that worked through that system got yanked in Europe and never came to the US. So, all that makes sense, right? We've gone through everything, and we made it in 2 hours. That's pretty awesome. What questions do you all have? That's a lot. I know it's deep. It's not just addiction is X, tolerance is X, dependence is X, because your exam, your patients are not going to present with, "Hi, my name is John. I've been taking alcohol at 1 pint of whiskey a night for the last 32 years. My receptors have done this," and yada, yada. No. What am I? It's not going to happen that way. So to me, it's a lot easier if you understand the physiological mechanism, and then either the physiology or the neuroanatomical pathway or the neurobiology to understand the disorder, then you can better understand how to treat it and have a much better potential outcome. Because if you merely memorize that alcohol withdrawal, I'm going to do X, well, people don't typically present that way to you. And so it's better to think outside of the X equals Y. You've got to understand how did you get to X and what happens between X and Y to understand what to do with Y. Okay? Questions? No? You all got it? Okay. So let's take maybe 10 minutes and then we'll do sleep